Can you all hear me? Is it audible?
Yes, sir.
Okay. Yeah. Okay. A sec. Yeah, sorry about that. So I'm actually in hospital. I'm in the middle of shift. So the connection is a bit poor inside the NIC. Okay. So uh sorry about that, right? So I'll be trying to make this as short and sweet as possible, right? To give you all a quick introduction about the OSCE in pediatrics, right? So at any time, if it's not clear, stop me and let me know, okay? Because the connection is a bit shitty over here. Yeah, sorry, wrong wording. It's a bit bad over here. Okay, yeah. Okay, give me a sec. Let me share my screen. Okay. So I hope that the MCQ exam was not too bad, right? Whatever the result of that, don't think about it, right? Prepare for the OSCE now itself, okay? Okay, can you all see the screen?
Yes, sir.
Is the screen visible? Yeah?
Yep.
Okay, so some of you all may not know me. My name is Nishan, right? So I'm a pediatric registrar in my second year of training, right? And I'm also a foreign graduate, like you guys who had to do ERPM, and I did ERPM in 2018, right? And yeah, I know it's been a long, long time and things have changed. But all in all, it's the same concept that's asked, and it's about the basics, right? At the end of the day. Okay. Right, so this is the new system, if I'm not mistaken. Where pediatrics, there'll be three sets of questions, right? So these three, as they have not been very clear, we do not know what the three questions are going to be. It can be a long case, short case, miscellaneous station, it could be a communication station, it could be any of it, right? So you need to be ready for all of the possibilities. Okay. So generally, this is the predicted timings, even though we don't know how it's going to be yet, right? So long case, generally, it's a 20 minutes, right? So you get 10 minutes for the history, the patient, what is the past medical history, so on and so forth, to the examiner in a sensible way. Then the history of this 6-year-old boy from his mother who has an education level till O level with a good understanding, who presented with cough for 2 days, which was intermittent in nature, whatever it is, and you had to come to a diagnosis, right? And then 8 minutes for the discussion. So discussion examiner will ask, what is your differential diagnosis? How are you going to manage a child? What is the cause of the disease, so on and so forth, right? Then short cases, 6 minutes to examine, 4 minutes to discuss. That's how it was before, right? It might change, right? It's just an estimate, okay? Okay, right? And, sorry, yeah. And, I mean, 4 minutes to discuss. So all the steps need to be done in a systemic manner, okay? And then you have the miscellaneous stations. Miscellaneous stations, we'll talk about that in a while. And of course, the communication station also generally is for 10 minutes, right? So you get around 5 minutes to prepare. They will give you a certain scenario. And then that you do the communication as well. Okay. So what are the possibilities here? So long case is the taking, as I said, then short case, you can get cardiovascular system, cerebellar system, lower limbs and upper limbs as well, and communication station, right? Syndromes can come under miscellaneous. Basically, they'll give you Down syndrome child, right? And you need to examine and figure out what the syndrome is. They might say just examine, do a general examination, or do a cardiovascular examination, whatever it is. They might give a syndrome as well, right? Then, of course, the miscellaneous stations, they can give you to measure blood pressure. They can give you a child and say to measure the height. They can give you a child and say measure the OFC, right? Or the short stature case, right? And then, of course, miscellaneous stations again, inhaler technique. They'll give a patient to you, right? And they'll keep an inhaler on the table and they will ask you to describe, okay, how are you going to use the inhaler? When are you going to use the inhaler? what are the precautions you're going to take, what are the possible complications that are going to be there, right? So that's another station. Okay, and then NLS, APLS, of course, that's neonatal life support and the pediatric life support that can come as a separate station. Okay, right. Is my audio okay? Can everyone hear me?
Yes, sir.
Okay, because the cameras went off all of a sudden as well. Yeah. Okay. Right. So pediatric history. Right. What is the important thing here? Wait, let me. So wait. Sorry. Right. So you get your ticket, right? So basically, this is just not for the exam purpose itself. This is just for the general purpose, right? You always write the date, the time, and your name, and then you start the clocking. Okay. Because if you miss that, legally you're in trouble. Okay, so it's very important. Then you write the patient's name. So here in pediatrics, why it's important, the name, right? So they can be twins, right? So they can be siblings. So don't go to write the surname, write the first name and the surname. Okay, and then the age. Why is the age important here? Right? Because of the developmental history. A child who is 1 year old and a child who's 2 years old will have completely different development. So you need to get the exact age. Mother will say, I'm out to but when you check and say he's 1 year and 3 months old, right? So then the complete history will be different. So get the exact age, right? And the sex of the child is important. Certain diseases are more common in different certain sex, right? Okay. So then here, and also you use appropriate terms. For example, a 6-month-old we call as a baby. So you can say baby Ashen, for example. But if it's a 5-year-old child, you don't say baby Ashen, you will say master Ashen. Okay. So use the appropriate terminology where it's required. Okay. Right. Wait, give me a sec. Okay. So then, of course, the current complaint patient will say, okay, fever is the most common complaint, right? So if you get fever, you need to analyze the fever. Okay. When did the fever start? From the day it started till today, is it a consistent fever? Is it an intermittent fever? Right? Or has the fever settled? And if so, has it been measured? If measured, how was it being measured? Because in Sri Lanka, most parents come and say, "Una tibba," how was it checked? With the palm of their hand. Sorry, with the back of their palm. Right? So that's not the ideal way to check. No? So you have to check how they check the temperature. If checked, whether it's documented. Because certain diseases have specific fever patterns, right? So all that we will discuss in detail when we're discussing the OSCE particular cases, but this is just general overview. Okay. So then after that complaint, they will say cough. It's cough again. How many days? What's the color? Is it is it thick? Is it watery? And is it progressive? Right. So all of this will help you come to your differential diagnosis. Okay. Then you take the history of the complaint. Okay. And then system analysis. So you have to analyze each system, right? From respiratory, cough, cold, cardiovascular, palpitations, chest pain, right? Then GI tract, diarrhea, vomiting, neurological, any fits, behavioral changes, skin, rashes, joint pains, so on and so forth. Each system, you need to ask few questions. Then the Panadol dose is very important in the pediatric population, right? Because in pediatrics, we give the Panadol dose according to the weight, right? So it might be an overdose in certain occasions because the parents might give the wrong dose. So 15 milligram per kilogram is the pediatric dose. You need to find out and say in your history when you're going to summarize it, a paracetamol dose is given, which is a weight appropriate dose, right? Those are key points. Okay. Then, of course, very important bowel opening, urine output, feeding, which I personally, when I take a history, I keep it as a separate section because I don't want to miss it. Okay. It gives out a lot of hints about dehydration, about the general condition of the child. Okay. Then you move on to the past medical history. So in adults, it's pressure and cholesterol and all that. But in the pediatric population, it will be more about asthma, more about febrile seizures, stuff like that. So it's a complete different entity or than a adult history. Okay, past surgical history generally not very significant, but can be. And then again, allergic history. And if the mother tells you, oh, allergic pain or cam welter, you have to find out, okay, cam or cam. පාඩු දානවද? හුස්ම ගන්න අමාරු එනවද? Some parents say, මෙයා මේක කෑම බඩ රිදෙනවා. What is that? That's because they get gastritis, for example, prawns and cuttlefish and all, right? That is not an allergy, no? So you need to exactly find out what it is. Because in Sri Lanka, they use these terms in a very common way. Like you say allergic, okay, stomach pain, allergy. Yes, it can be a sign of allergy, but generally it's more towards the gastritis side, right? Okay. Then here important is the birth history, right? You need to go into detail. What's the birth weight, mode of delivery? If it was a C-section, why was it a C-section? Was it a planned delivery? Did the mother have the rubella vaccine? Why is this important? We don't know if the child has congenital rubella, right? So rubella vaccine is given, and so on and so forth. And the complications, whether the baby had an NICU stay, if so for how long, was antibiotic was given, right? These are very important. Okay. Then developmental history. So we have to make sure it's age appropriate, right? Gross motor, fine motor, speech, social. So how I do it is for every age. So every age means obviously not every month. So break it down. So I break it into 3 months, 6 months, 9 months, 1 year, 1.5, 2, 2.5, 3, 3.5, 4, like that. And each age, for each gross motor, fine motor, speech, social, I remember 1 point. So that it helps me exclude any developmental delay. Okay. So obviously you're not going to know all of it. You'll know only some of it, right? So for the exam, especially memorize 1 to 2 points for each age. So you can ask to exclude any developmental delay. Okay. Immunization history, in and out, you should know it, you should by heart it. There's nothing to understand there, right? And of course, in if certain children, immunizations which are out of the vaccine schedule are given, right? So for example, in your history, if you get a, if it's a recurrent infection history, right, you need to ask about the extra immunizations like pneumococcal vaccine, for example, which would be given if there's a child who's prone, for example, chronic lung disease. Okay, right? And then, of course, the growth, generally from your examination on, you check the weight, height, and all of that. But sometimes mother might say that the weight and height is is low. The child might be having SAM or MAM. The mother itself might tell you if she knows, if she's quite educated and knows about the condition. Okay. Then diet history, breastfeeding till when, right? In Sri Lanka, as you all know, breastfeeding till 6 months is uh, recommended only, and then we wean after 6 months. However, weaning can be done beforehand for certain indications, which we will talk about uh, in detail later, right? And of course, then now this is child an adult meal, how the calories also, right? But given your 6 minutes time, there's not enough time to do all that, but you can just take a rough history, okay? Contact history depending on the illness and the family history, of course, whether there's any consanguinity, right? Why do we need consanguinity in pediatrics? Higher chance of autosomal recessive conditions, okay? And then, of course, the mother and father's education level, because when you're talking to her, depending on the education level, the way you explain things might vary. Okay. And then the social history, again, what about the schooling? What about the environment? Especially if it's an asthma case, you need to exclude any possible triggers, any possible risk factors. Yeah. Okay. So that is basically the pediatric history. Depending on the system, depending on the case, I will go into detail with each when discussing each topic. Okay, this is just a general overview of how to get the pediatric history. Okay, and another very important thing, especially for exam purposes, right? If you're talking to the mother, okay. Yeah, sorry, yeah, got a call about delivery. Yeah, it's all good. Yeah, sorry. And yes, so where was I? Can someone tell me where was I? If I lost my train of thought.
You said some important point about when you take history or something after describing all this social
Yeah,
history
yeah,
and
yeah,
all.
yeah, yeah. Sorry. Yes, yes, yes. It's good. Yeah. So when you're talking to the mother, right, you have to also interact with the child, okay? Because it's a pediatric child. That's a very, very important thing, okay? You're interacting with the mother, you're talking to the mother, but the child is also there sitting most of the time. So you need to talk to the child, okay? Have a not, not full-on conversation, but interact, maybe make some eye contact, smile at the child, say something here and there to the child, okay? because it is a child, okay, and he or she will feel awkward and off, and because the whole day the child is in the exam, okay, and especially when you're examining as well, talk to the child. Let's say the 6-year-old boy, talk to the child. I mean, while examining his abdomen, for example, one other cavity, have a conversation, right? Then you don't feel the 6 minutes going also when you're examining, and the examiner knows, okay, you know what, he has a good rapport with the child, right? So that's a good thing. That's how a pediatric doctor should be. Okay. So don't forget that as well. Okay. And let's say it's a 10-year-old boy. When you're taking the history, you can ask some questions of him as well. Like the mother says, abdominal pain, you can ask him. So where is the abdominal pain mainly located in, right? But when does it reduce? Okay. So depending on the age, you can ask some questions of the child as well. Okay. Right. So possible cases, definitely neuro in pediatric, most common would be febrile seizure. GI system would be acute gastroenteritis. Respi, generally it would be bronchial asthma. Nephro, it would be more nephrotic case, right? And joint pain, very non-specific, but it could be related to any infection, right? Right. So we can practice a long case, right? Just for around 5 minutes, quick history. I need someone to volunteer, okay? Someone to unmute and oh, sorry, was my camera off all this time? Sorry, my bad. Need someone to unmute and or on their camera. Anyone, just volunteer just for a few minutes, practice. This is the best time to practice to learn, right? I'll be the patient, right? And you can take the history from me. Someone volunteer. Just for a quick history, maybe 5 minutes. You can call out a name from the chat box. Let's see who's there. Imani, you want to volunteer? Imani Vidanagama. Okay, you don't have to on the camera. Just you can open your microphone on your microphone, right? Just a few minutes, it'll be quick. Good way for you to practice as well.
Shall I go with that?
Yeah, sure.
Hello.
Image. Yeah.
Yeah.
So okay, so basically, I'm the father of a 7-year-old boy, right? And you can take the history just just for a few minutes. You can take it and we'll see.
Should I continue with Sinhala?
Yeah. So the exam single, yeah. Yeah.
Okay. Good morning, Tata. බබාගේ නම මොකක්ද?
Suresh.
වයස කීයද තාත්තා? බබාගේ වයස කීයද?
7යි. 7යි.
ඇයි අද හොස්පිටල් එකට ආවේ? මොකක්ද හේතුව?
ඊයේ රෑ ඉඳන් උඩ ડોක්ටර් එයාට අඩුවෙන්
තාත්තා ගෙවල් කොහෙද?
මේ ළඟ ඉස්පිරිතාලේ විනාඩි 5යි.
උණ කවදා ඉඳන්ද තිබ්බේ? උණ කීයට තිබ්බද? කියන්නේ උණ මැන්නද? උණ කට්ටකින්?
මැන්නේ නම් නෑ ડોක්ටර්. ඔළුව අරලාදී ගොඩක් ප්‍රශ්න තිබ්බා. ඊයේ රෑ ඉඳන් වුණා දැන්. ඊයේ රෑ ඉඳන්.
උණත් එක්ක තව මොනාරි ළමයට අමාරුකම් කිව්වද? බඩ රිදෙනවා, කෑම කන්නේ වෙනස්කම් මොනාරි තිබ්බද ළමයාගේ? නැත්නම් උණ විතරද?
අද උදේ නිකන් අත් දෙකයි කකුල් දෙකයි ගැහෙනවා වගේ තිබ්බා. මේ අපේ වයිෆ් නම් කිව්වා ඒක ෆිට් එකක් වෙයි කියලා. ඒකයි එයාව ඉක්මනට හොස්පිටල් එකට එක්කන් ආවේ අද.
හෙම්බිරිසාව උණ කැස්ස මේ ළඟදී එයාට හැදුනද?
නෑ එහෙම නෑ.
එහෙම නෑ. ගෙදර තව කාට හරි මෙහෙම තියනවද උණ හැදිලා තිබ්බද කාට හරි?
නෑ. දන්න තරමින් නෑ.
Um, uh,
So I said now that there was some abnormal movement, like, no, you want to ask any
yeah.
questions about that?
ළමයාගේ අතපය ගැහෙනවා කියලා කිව්වා. එතකොට අතපය ගැහෙද්දී ළමයාට සිහිය නැති වුණාද? නැත්නම් කට පැත්තට ගිහිල්ලා ඇස් උඩ ගිහිල්ලා එහෙම වෙනස් වීම තිබ්බද?
ඇස් දෙක උඩ ගිහින් තිබ්බා කතා කරාට එයා මුකුත් කිව්වේ නෑ. ඇස් දෙක උඩ ගිහින් තිබ්බා කටින් සෙවා වගේකුත් ආවා.
ළමයා කාලා බීලාද හිටියේ?
නෑ ඒක හැරිච්ච වෙලා වෙච්ච ගාම තමයි ඒක හැදුනේ.
ඒ කියන්නේ ඊයේ රෑ කෑමට ඉස්සෙල්ලා තමයි ආවේනේ.
නෑ අද උදේ කෑමට.
මීට කලින් මෙහෙම වෙලා තියෙනවද තාත්තා? කියන්නේ උණත් එක්ක ෆිට් එක වගේ ඇවිල්ලා තියෙනවද? නැත්නම් මේ
නෑ
පළවෙනි
මේක
පාරද?
තමයි මේ පළවෙනි පාර.
ළමයාට තව මොන හරි ලෙඩවලට බෙහෙත් ගන්නවද නැත්නම් ඒ කියන්නේ දීර්ඝ කාලීන මොන හරි
එහෙමනම් නෑ. එහෙමනම් බෙහෙත් ගන්න නෑ. සාමාන්‍ය ඉතින් එහෙම ලෙඩ වෙන්නේ නෑ.
sorry I couldn't hear it properly.
බෙහෙත් ගන්න නෑ. එයාට එහෙම ලෙඩ සාමාන්‍ය හැදෙන්නේ නෑ.
මෙයාට සහෝදර සහෝදරියෝ ඉන්නවද?
ඔව්.
එයාලගේ වයස කොහොමද? එයාලටත් මේ වගේ වෙලා තියෙනවද කලින්?
එයාගේ මල්ලි කෙනෙක් ඉන්න අවුරුදු 3යි නෑ. එයාට හැදිලා නෑ.
මෙයාට හතිය එහෙම පොඩි කාලේ හරි තිබිලා තියෙනවද?
එක සැරයක් නම් තුන් අල්ලලා තියෙනවා එච්චරයි. ඒත් නැත්තම් එහෙම හැදෙන්නේ
අම්මා තාත්තා මොනවද කරන්නේ?
නෑ. මම ත්‍රිවිල් එළවන අම්මා ගෙදරේ.
එතකොට පවුලේ කී දෙනෙක්ද ඉන්නේ? ඔක්කොම?
මායි 4 දෙනෙක්. Okay, you're done asking about the symptoms, is it?
Yeah, mostly.
Okay, that's good. You good. Thank you for trying, Imesha. Very bold of you. So that's good. That's how you learn, right? That's the way to learn. Is you have to keep trying. Okay, you have to keep trying, right? The first time you take a history, the first time you examine a child, the first time you carry a baby, right? It's going to be challenging and it's going to be difficult, right? But the more you do it, the more comfortable you get with it, the more easy it becomes, right? You take me, for example, like when I did ERPM in 2018, okay, when I came back, I wasn't very fluent with the system and I wasn't very good. I mean, I had but carried a baby, to be honest, right? In like, how I do now. So it took me time to learn, and what I did was I put myself out there a lot, right? I used to record histories and or send it to my seniors to help me for them to correct my presentation of his summaries. And I took as much histories as possible, whenever possible, short cases. What I did was I practiced on my friend the examination steps so that I don't make the mistake in the exam, right? So do whatever it takes. Don't stop trying, keep working hard. Okay, don't worry. Very doable exam. Okay, so good. Thank you for trying. Okay, so basically that's how history goes, right? So you have to go in a more systemic way. Okay, so if the and your main thing is ask open-ended questions. Okay, so in a way, and give time for the parent to answer as well, because they will give long answers sometimes, right? So allow them to give answers as well. And if they say a complaint, for example, if they say a fit, right? So try to analyze that symptom before moving on to the next. Okay. So try to find out, was it a generalized fit? Was it a focal fit? Right? And then was it tonic-clonic? Was it myoclonic? Was it atonic? So all that has to come from the history. Okay. So always analyze each symptom that what they say and then move on to the next. Okay. Then it will be a very systematic way. The main thing is being very systematic. Okay. So the examiner knows, okay, you know what? He knows how to work or she knows how to work. So yeah, I trust him to be in my ward, right? That's what they want. They expect you as the house officer to do when you're in the night alone in the ward, that they can trust you to keep their patient safe. Okay. So, okay, yeah. So basically, that's how a long case goes. Obviously, in the exam, there'll be much more pressure. You're bound to forget things. You're bound to forget questions, and that's completely fine. That's how it is for all of us, right? But as long as you keep practicing, you won't miss the steps. You will know, okay, current history, then past medical, social, surgical, allergic, birth, development. If the more you practice it, the more fluency comes in the exam. When you're writing, automatically the questions will come to you. Okay, right. So that's the long case. What about the short cases, right? So cardiology, these are the lists that are common in the pediatric population generally. Okay. So you have the VSD, ASD, AVSD, DDA, and all of it. But if you take common wise, VSD would be the most common. Okay, ventricular septal defect. So whenever possible, if you're on YouTube, you get plenty of videos of VSDs, right? Listen to it. Okay. And then you get used to the sound of the VSD. Then comes the ASD, okay? And AVSD is what you get in Down syndrome, okay? So practice listening to the normal sound as well. When you're at home, you don't have to do anything fancy. Your brother might be there, your sister might be there, your father might be there. Examine him, examine his heart, examine her heart. Listen to the normal heart sounds, lub, dub, lub, dub. When you hear that, when you go to the exam, you keep the step, you will hear the abnormal sound because there will be a clear-cut murmur. Me, for example, I got cardiovascular for one case in my pediatric short case in ERPM. It was a VSD. Before that, I hadn't heard a proper VSD in a child, right? I put the step on the child. The moment I put it, I heard the murmur. I knew this is a VSD. Okay, that's because I listen to the normal sound as much as so that if you know the normal, the moment you go to the exam, you hear the abnormal, you know this is abnormal, right? And then, right, at the exam, it might be this is normal child with no cyanosis. This is a child with cyanosis. You can identify that 50% you're already there. Okay. So know the normal thing perfectly, then you will identify the abnormal thing. Okay. Right. So if you take cyanotic heart disease, tetralogy of Fallot is the most common disease that they're going to give you. Okay. So when you're studying, PSD, ASD, and TOF should be your main diseases which you're very, very fluent in. The other ones can come, just know a bit. Okay, very unlikely. So the ones that you know are going to come are the ones you should focus on when you're studying. Okay. So short cases, obviously, there are that would be inspection, palpation, percussion, auscultation. Okay. So that's the general. Inspect, then you palpate, then you percuss, then you auscultate. Okay. Right. Then respiratory again, most commonly they give is bronchial asthma. It could be exacerbation of the child, right? Another important thing in the pediatric population is observe the child's weight and height. Okay. Any short case you get in pediatrics, right? How you present your case first is I've just examined a 6-year-old boy who appears to be well grown for his age and height. Although I would like to plot his weight and height on the centile chart to confirm my assess his growth. You have to comment on the growth always. You don't comment on the growth, you might not pass the exam, right? Because for pediatrics, syndromes, another. So if you don't identify these, then they might not pass you because they don't expect you to find the diagnosis. Let's say you miss a VSD, you say ASD for a VSD or a ASD for a VSD, they won't fail you, right? As long as you do the steps properly and you present in a sensible manner. Okay. So always pediatrics where say weight and height, you have to comment. For example, if it's a 10-year-old boy and you see child is not adequately grown, you can say the child doesn't look adequately grown for his age, although I would like to plot it on the centile chart to confirm my suspicion. Okay. And of course, you have to say whether the child is syndromic or not. These two things are essential. Okay. Then respiratory, of course, commonly as in bronchial asthma, pneumonia is possibility. Pleural effusion pneumothorax in a pediatric population, they're giving you for the exam is unlikely. Okay. Again, bronchiectasis, yes, you can get chronic lung diseases. Children are there in Sri Lanka. For example, cystic fibrosis patients. Okay. So again, you have to be very alert when you look at the child, and if you see the child doesn't look adequately grown for the age, suspect a chronic disease. Okay. So how do you get used to that? Walk around in your neighborhood, see your neighbors, children, playing in the grounds. Just have a look and see, okay, think, okay, this child looks like he's 7. Is he 7? Right? So you have a general idea. When you look at a child, you can get a rough idea about the age, right? Depending on, whether they're thin or slim or whatever it is, okay? So have an idea about that, yeah? Okay, so then if we move on to neuro aspect, cranial nerves can be given. Pediatric population, most likely if they give, it will be the facial nerve. Okay. And of course, 3, 4, 6 cranial nerves also is a possibility. It's a bit difficult to examine in smaller children, but let's say it's a 10-year-old, 8-year-old, it's possible because they need to be very compliant with examining it. Okay. So pediatric population, when you study cranial nerves, focus on those. Then cerebral examination, again possible. Okay. That's actually one of the easier ones to examine, and I will go into detail in that in our OSCE classes, right? And again, in all these examinations, it's about the systemic approach. Okay, always when you're giving answers, also in the OSCE, be systematic. Okay, they'll ask, so will okay, the exam will ask, okay, what are the possibilities that can cause this in the child? Then your answer should be, so there are a lot of possibilities. Uh, First group would be infections like TB. And then so other possibilities, autoimmune conditions like SLE. Also, sir, hematological conditions like leukemia. You get it? Whatever it is, don't go saying, sir, TB, this thing, hemolysis, whatever it is. Don't be haphazard. Always be systematic and give it in a proper manner, the answers. Okay. Then, of course, abdomen, you can get hepatomegaly, splenomegaly, combined abdominal masses is more in surgery short cases, whereas in peds, hepatomegaly, splenomegaly is common, is a more likely case to be given. For me, for example, I got it for my ERPM case, pediatric. I got it for my MD case. I got it for my DCH diploma case also. So abdomen is a common case, right? And you have to be careful. It's not easy to examine a child's abdomen, but again, practice makes perfect. So don't worry, we'll definitely get there, right? So yeah. Then of course, lower limbs, again, commonly that can give cerebral palsy, right? Again, watch videos on YouTube. They will show you typical children with cerebral palsy. How when you look from a distance, you can see the contractures, the tone is increased, the abnormal posturing. There's something called scissor legs, right? Then the frog posture. All of these can be seen from a distance, right? Before you go close to the child as well. And then spinal abnormality. So pediatric population, that's another important thing, right? Spina bifida, that can lead to lower limb problems. Okay. Muscular dystrophies like Duchenne. Yeah. That's where you need to know a bit of theory. Because they'll ask then what is the inheritance, right? What is the dystrophin abnormality, right? They can ask about that. So those kind of questions can be asked, but the theory aspect won't be asked into detail in the discussion, right? Discussion basically they'll ask is, okay, if you say this is my diagnosis, they will ask, okay, why do you suspect it? What are the findings that are positive for it? Okay. Then you can say if you're saying quadriplegic cerebral palsy, you can say all 4 limbs have increased tone, increased reflexes. So then they will ask what are the possible causes. Then you can say there are antenatal causes, perinatal causes, postnatal causes, and break it down. Okay. And then the discussion will go on, and then they'll ask management. Then they'll ask what can you do for this child additionally, right? Depending on whatever the child has. Okay. So you should have a bit of mention a bit about the social help as well whenever possible in your discussions. Okay. Then neonatal examination again. So basically, it's not given as commonly as the other ones, although it's a possibility. And if they do give, it's high chance it will be a normal neonate, and they will give it to see whether you can handle a neonate examination. When neonates, the method of examining is complete. So it's not easy for someone who hasn't done it before, right? However, it's very doable. Okay, so we will talk about that in, in one of those classes, right? But remember, neonatal examination also can come in your OSCE exam, okay? But very unlikely they, right, without making the baby cry. Of course, in the exam, there's a chance the child will cry. So be very careful. I know you will examiner sees that the child is irritated and crying, not because of what you did. That's not going to be a problem. Be careful, be very gentle when you're examining children. They are children. Okay, so don't be too rough. Okay, smile, be friendly, talk with them. Okay. This exam, this is the points used to pass the exam. Okay. Even though I look like a dark, scared, change
Your
entirely.
connection is
Okay,
not very
so you got
clear.
to adapt to the situation and do whatever it takes to pass the exam. Yeah. Okay. Then communication, right? So basically, is a possible stage. So this generally doesn't come in. Sorry, did someone say something?
So you were not
Connection is
here
not very
with the
Someone say
neonatal
anything?
exam.
Okay. Yeah. Someone wants to volunteer to do communication. Sorry.
So I think there's a small connection problem going on, and it wasn't clear with the neonatal examinations.
What happened? Okay. Okay. Can you all hear me now?
Yes, sir.
Okay. So yeah, sorry about that. Yeah, as I mentioned, the connection is a bit bad over here, right? Hello, can you all hear me now?
Yes, sir.
Sorry, I had to come all the way down because the connection is really, really bad. I don't know. Okay, so y'all can hear me now. Wait, let me share. I'm on the phone. Let me see if I can share this now. Give me a sec, guys. Really sorry about the inconvenience. Yeah. Okay. Can you see the screen now?
Yes, sir.
Okay, right. So we were going to be in communication now. Okay. So basically, this is the type of communication you can get, right? It'll be, they'll say 5-year-old suspected of having ALL, as you know, acute lymphoblastic leukemia, from a blood picture is be transferred to undergo bone marrow biopsy. Father has concerns, address them and explain regarding the current condition. Okay, so you'll see this case scenario. They'll get 5 minutes, and then they'll ask you to talk to the father. Okay, so I will at the moment, right? But generally, how it goes is, okay, you'll have to build a rapport firstly, right? So you need, generally communication is done in English. Okay, history is in Sinhala, discussion is in English, communication be acting as the father or the mother. Okay, so you have to address them, right? You have to address the concerns. You have to ask open-ended questions. So communication station is an art. Okay. So over here, another tricky part is here they have said suspecting ALL. So you have to tell the parents that it is a possibility. They are going to ask, "Mage putata," or in English, does my child have cancer, right? And you have to say it is a possibility, although we cannot say 100%, right? If you go to say yes, he has it, and all that, then they might not pass because here they say suspected. So to be very careful, right? That's the whole point of the communication station, right? Other possibilities of a communication station is they can ask you to take consent for a lumbar puncture. Okay. Other possibilities would be explaining about the prognosis of a condition, whatever it is, you have to, as a systematic way, right? So communication, next slide. Can you see the next slide? Can see, yeah? Can you see?
Yes.
Okay, so introduction, obviously you have to first say, or when taking the long case also, you have to say, like for example, my name is Dr. Nishan. I'm the pediatric doctor in this ward. I have been informed that your Sinet's father. Is it okay if I talk to you now? Is this a good time? Right? So that's how you introduce yourself and you build the rapport. That's the first thing they see. Okay, so you have to talk to the father, find out whether he's from a nearby place, how long has he been here waiting for you to talk to you, right? Make them feel comfortable. Okay, that's the first part. Then you have to make an agenda. Okay, so ALL. So the concerns, the questions they're gonna ask, and you have to have in your head, okay, these are the possibilities. This is what I'm going to be ready with. Okay, because you get time beforehand to prepare, right? So they're gonna ask about the prognosis, right? They're gonna ask about the complications. They're gonna ask about the treatment. They're gonna ask whether their second son or other child can get it. So all of these have to be in your head. You have to ask open questions. That's the important thing. Okay, you have to let them answer. So you have to say, okay, what are your concerns? Then they'll be like, this. You ask, okay, I understand. And all you have to show empathy. You have to show understanding, right? You'll be like, yes, I understand your concerns. Okay, is there anything else that you want to ask me? Okay, then you have to gather the info questions. You don't answer one after one after one. You gather all the concerns and you address them one by one afterwards. Okay, and you find out what they know as well. You can say, have you heard about ALL? If so, what do you know about it? Right? Always try to do open-ended questions. Yeah. Then gather it all and then you address. So, for example, Mr. Perera, you wanted to know about the complications of lumbar puncture. Infection is a possibility, although we'll be doing it in a very sterile environment. Have I addressed the concern? Is there anything else you want me to not to know about the complications? Right. Okay. So then shall we move on to the next one? And like that, you have to address each of it and you have to always check whether they understood what you say. And you cannot use medical jargon. Okay. You cannot say, for example, how do you say? Whatever it is, okay, it's coming to head, but you can't use medical jargon, okay? You have to use common layman terms when you're talking to a non-medical profession, okay? Show empathy, give space and time to process the situation, okay? Definitely, okay? There's an instance the mother might cry, they might be in shock, so you have to give some space for them to process the situation. You cannot rush into it, okay? And at the end, you summarize. You can be, okay, Mr. Perera, so today we spoke about the risks of LP, the benefits of LP, and we are going to do whatever we can to make your son better. So if you're okay with it, we can go ahead with the lumbar puncture today. And if you have any other concerns, you can come to the ward and talk to me. I'm always here. And to help you out, I can also link you up with some websites with further information, right? So that's basically the communication station. Okay. So you have to keep practicing that, and to practice that, you can practice among your colleagues, right? You can ask your friend to act like a father or the mother, and you can do the communication station with them as well. Okay, I know this is a completely new entity, but it's very doable because this is in English as well. Okay, then of course the possibility of syndromes, Down syndrome, most common one that will be given, right? So best way to get used to it is Google images of syndromes, Down syndrome, Noonan, Turner, Marfan, whatever it is. Just go through syndromes when you're at home, when you're free, when you're just before you go to sleep, you're all on TikTok and Instagram and all. No? Just get on Google and just type syndromes, common syndromes. Just look at pictures. Get used to it. Look at pictures of clubbing. Look at pictures of cyanosis. The more you see it, the more familiar you get with it, and the easier it becomes. Okay. Then miscellaneous stations. Of course, blood pressure checking, right? So then they will check your technique. And then of course you need to measure the height also. It's one thing. Then to check the occipital frontal circumference, measuring the height, short stature assessment, right? There are certain techniques you need to know, certain maneuvers you need to do. You have to check the mid-parental height, right? So all of this we'll talk into detail later on. But this just to give you an idea as to the possible cases you can get so that you can now itself read around them, get familiar with the possible cases that can come. Okay. Generally, in miscellaneous, they will just assess your technique, whether you know how to actually do it. Okay. Right. Then, of course, inhaler technique is something they can ask you, right? So you should have an idea about what are the inhalers, the colors of the inhalers, when to use, how to clean, when to seek medical attention, right? These are the things they expect the house officer to know because you're the one who's going to give the advice to the mother and father, okay, and the child itself. So that's very important to know, okay? So that also you can practice day to day when you're talking to your friend and all. You can say, Machang, you're the asthma patient. I'm going to teach you to use the inhaler. And you teach him. Okay. If you don't practice it, when you go to the exam and you get it, you will forget a lot of important points. But if you have practiced it and you forget something while you're practicing, when you go for the exam, you won't forget it. I know when I was a student, this was told to me by my lecturers and examiners. And I was like, you know what, I'll go to the exam and do it and all that. But what they say is true. If you don't practice it beforehand, it might be a bit more difficult in the exam. Okay. Then down to the last two things. So APLS, the pediatric life support station, right? So a general case they can give you is, for example, let's say 4-year-old boy with history for fever for 6 days, no urine out for 5 hours, BP 70/50. How do you manage the patient? So you have to always use the ABCDE approach, right? Which we'll talk into detail later. But here again, what they expect is for you to make sure the patient doesn't die. Okay. So you just have to do the basic resuscitation until your seniors arrive. Okay. So that's the main thing here. And there's something important in APLS, which is the wet flag, because in the pediatric population, the drug doses, everything varies with the age of the child. Sorry, with the weight and age of the child. Right? Okay. So that's something to know. For example, in the age less than 1 year, age in months divided by 2 plus 4 is the estimated weight of the child. Okay. And wet flag is basically for us to know. W is for weight. E is for the energy, kilojoules, in case you need to shock the child. That is 4 joules per kg. T is the tube size for intubation. That is age divided by 4 plus 4. Then F is for fluids. G is for the glucose, right? A is for the adrenaline, and L is for the it's the midazolam one, right? In case of seizures, okay, right? So wet flag. So L they usually say lorazepam, no, but we usually give midazolam, okay? So, but how you would approach these cases? You would say I would come and attend the child, put the child to the resuscitation bed, assess the airway, and then you go step by step breathing. It's A, B, C, D, E. You go in the systematic way. Again, here, that's what they want you to do. You know, always tell. I would also ask one of my colleagues to talk to the mother, to reassure the mother, and make sure the mother is not in the danger zone. Okay. Those are important points which you need to know, especially in the pediatric population as well. Okay. Then if it comes to NLS, this is the neonatal one. As we all know, neonatal is something we are not very familiar with unless we actually work in the NICU setting, right? So you should have an idea how to prepare the delivery area before a baby is born, right? So you need to check the equipment, check the temperature, make sure the warmer is ready, make sure there are wet towels and so on and so forth, right? And then a case you can get this, they will tell you. So basically they'll give you a dummy, okay? They'll give you a dummy and they'll keep the equipment and they will expect you to pick the correct size, right? And they'll say you're called to attend a delivery. Baby did not cry at birth. How will you manage the baby, right? So as you all know, in neonates, it's a completely different thing where you need to first warm the baby, stimulate the baby, keep the head in neutral position, assess the CTBH, color tone, breathing, heart rate. That's your go-to thing in neonatal life support. Okay, it's again can't talk in detail later on when we are discussing about NLS in one of the OSCE classes. Okay, so again here the main important thing is stepwise, right? And I'm talking about this that you all have an idea that these are the possible cases that you all can get in the OSCE. Okay, so let me summarize it again. So OSCE possible cases is long case, short case, the common ones as you all know. Then the new ones that will come in, so neonatal examination comes under short case. Communication, again, one of the new ones. Miscellaneous station, again, one of the new ones. And NLS, APLS, again, one of the new ones. These can be included in the OSCE format. Okay. Yeah. So that's basically how the OSCE is going to be in pediatrics, right? Sorry about the poor connection. There's just really bad connection in the ward. And yeah, I had to rush through to finish it off for you guys. Unfortunately, we couldn't do a demo communication as I was planning to, right? So we can do into detail and do the demos when we are doing the OSCE classes, okay? Are there any questions about the pediatric OSCE setup that you all want to ask me?
So in the miscellaneous stations, will we get BP cuffs and those things, or we have to bring our own things?
No. They'll give all the equipment will be provided, right? You just have to carry we'll tell you all actually. So basically you have to carry your knee hammer, stet, pocket torch, then Snellen chart, a piece of cotton wool for the neuro exam and all that you need to take, right? But BP cuff and all will be given, but tape also we usually carry because you need to measure the liver and spleen. No? So generally you should have a small box with all those. And for pediatric ones, you need to carry toys, again important, because after you examine each child or take a history from each child, you need to give a toy to the child. Okay, it's expected, right? So you have to carry toys from varying categories. You have to anticipate a toy for a 1-year-old child and also for a 6-year-old child, and for boys and for girls. So you have to carry multiple toys and go for the exam as well. Okay, that's another important thing which you have to do. Yeah. Any questions about pediatric OSCE setup that you want me to address? Right, so don't worry, right? It's a very doable thing. I know they have changed the setup that it's a bit frightening and you're a bit worried about it, right? But there's nothing to worry about at all. Trust me. Okay. The exam it seems hard. It is if you don't prepare well, right? So keep practicing. As I said, know the normal thing very well. And the common diseases, know it inside out. The rare ones, it might come, it might not come. Even if it comes, it's okay, right? As long as you do the steps properly. You can get the diagnosis wrong. That's okay. They will not fail you for that. As long as you do the steps correctly in a very systematic way. That's what's expected from you guys as pre-interns. Okay? Right. So again, sorry about the poor connection and the rushed introduction. Unfortunately, due to the circumstances I'm facing, right? But hopefully we'll be able to do better classes and more detailed ones when we discuss the OSCE topics, okay? Yeah, if there are no more questions, then I think we can end the lecture. Right? Okay. If there's anything, please don't feel shy to reach out to me. You can contact the admins and they will reach out to me anytime, any day. You can ask any question about pediatrics on me, and I'll help you out as much as possible. Okay. Okay. So if there's no more questions, then thank you for joining. Sorry about the inconvenience and good night. Okay.
Thank you, sir. Good night.
Thank you, sir.